Good afternoon, everyone. I'm Barbara Ham-Lee. Up next on Another View on Health, African Americans and stroke. Strokes are the third leading cause of death in the African American community. Those who survive often come out of a stroke disabled, unable to walk or speak. Michael Walker is here today to share his experience with stroke. Dr. Beverly Roberts-Atwater gives us insight on the rehabilitation process. And guest host Dr. Keith Newby reminds us again why obesity, high blood pressure, heart disease, and diabetes create a greater risk of having a stroke. Another View on Health is next, right after this news from NPR.
Discussing today's topics from an African American perspective, this is Another View.
Good afternoon, everyone, and welcome to Another View. I'm Barbara Ham-Lee. Today on Another View on Health, we're going to talk about stroke, what it is, how it happens, how it's treated, and how to prevent it. But first, I want to spend a few moments with one of our favorite guests on Another View. Charlie Hill is the president of the Hampton Roads Prostate Health Forum, and he is a thriver of prostate cancer and one of the most passionate advocates for education and testing for this disease that we know. Hi, Charlie.
Hello, Barbara, and thank you for such a wonderful lead-in.
You're very welcome. So there's something going on in a couple of weeks, I think a week from Saturday, right?
Yes, Saturday, February the 7th at the Queen Street Baptist Church Fellowship Center in Hampton.
Mm-hmm. And what's happening?
We're offering our fourth prostate cancer early detection workshop, test, and exams. Workshop, meaning women and men, male and female, are invited to come and learn all they want to know about prostate health, prostate cancer in particular, and then following the workshop, we're going to provide PSA tests, blood tests for men, obviously, and digital rectal exams. So it's a full-service morning from 8:30 a.m. until 11:30, and we want to pack the house.
Okay. Now, is there a charge?
No, that's a wonderful question. There is a cost, but the cost is being taken care of by our wonderful and generous supporters. So for the participants, it is free.
Correct. Yeah, fantastic. How do people register, Charlie?
All they need to do is call 757-827-0488, leave their name and telephone number or some other way to contact them. We like to call everybody within 24 hours of the event just to make sure that they're on board and they're going to be coming. So we need a way to contact them.
Okay, and Charlie, we know that prostate cancer only affects men, but why is it so important for women to come with their spouses or significant others?
Because when a man has prostate cancer, it affects everybody who loves him, who is close to him, because it changes almost everything that man feels and knows about himself. And we really have to understand how important it is that we know how a man is impacted. His self-esteem, his confidence, how he views himself as a man these things are all challenged. Mm-hmm. And we need to have folk who are around him understand that, so that they can work with him. I like to say men can only get prostate cancer, but the disease impacts the entire family, wives, and other loved ones who are actively involved in his life. So when we talk about Save Our Men, that is what we're talking about.
Okay, Charlie Hill, we really appreciate you spending some time with us, here on Another View. And the event is Saturday, February the 7th, 2015, from 8:30 until 11:30 a.m. at Queen Street Baptist Church Fellowship Center, 98 North Armistead Avenue in Hampton. If you want to register, call 757-827-0488 and come on out. It's free, and you need to take care of your prostate health. Charlie, thanks so much for joining us.
Thank you, and have a great show. I'll be listening.
Thank you so much. Take care now.
Bye-bye.
Bye-bye. Okay, stroke. Stroke, a debilitating condition that is 50% more likely to affect African Americans than Caucasians. It's the third leading cause of death in the African American community, and it can be prevented with changes in our lifestyles. Joining me to talk about stroke and its consequences is my co-host for Another View on Health, cardiologist Dr. Keith Newby. Happy New Year, Keith, because I haven't seen you.
I know. I tell you, I thought you didn't want to be bothered with me anymore. How you doing,
It's
Barbara?
been a while. Glad to have you with us.
Thank you.
Physiatrist Dr. Beverly Roberts-Atwater with EVMS. Dr. Roberts-Atwater, how are you?
I'm doing fine. Thank you so much for allowing me to participate in this conversation
we are very excited
today
to have you here.
with
Absolutely.
the renowned Dr. Newby.
Oh, yes, absolutely. The renowned Dr. Newby. And Michael Walker, who is a master control operator here at WHRO and who also suffered a stroke 14 years ago.
Yes, 2001.
That pretty much altered your life, didn't it, Michael?
Yes, it did. Barbara, thank you for having me here.
Thank you for being here. So talk to us about what was going on 14 years ago when you had your stroke. What was happening?
Well, I was on an emotional roller coaster. The stroke involved, actually, it kind of brought everything into focus as far as where I was in my life at that time. But I was on an emotional roller coaster at the time. I was not managing my stress very well. I was the poster child for poorly managed stress management. So the things that were happening to me, I guess, are typical in terms of a stroke victim. I actually had been diagnosed with elevated blood pressure back in my 20s, and all I had to do was take one little pill a day, and I was not medically compliant. And any bad patient or any good doctor knows that if you have a poorly compliant patient, they're not going to their condition will turn into ultimately disease.
So when you were going through this, so you were like 35, 36,
I was
somewhere in
35
there?
years old when I had the stroke. I was about 26 when I had elevated blood pressure, and I had to actually take the little pill. It was a Norvasc pill. I was on Norvasc for that time, but I just didn't take it.
You just didn't take it.
Yeah, and over time, things would happen. And then, of course, if you have a habit of not managing your stress or dealing with things where you should, a lot of things will exacerbate, and that's one of the things that happened.
So the day that you had your first stroke, because you had multiple strokes, is that correct?
Yes, I did. Yes, and they're very hard to happen. I guess the doctors could speak to that too. They're called transient ischemic attacks.
TIAs.
TIAs, yes. And I was having the symptoms of them while I was on duty at work. I was involved in a production, and one of the more astute colleagues of mine noticed that I just wasn't quite right. There was something a little bit off about me. And I'd gone through the entire day. I was feeling nauseated all day, but I just figured it was just I wasn't feeling well, and I basically didn't really pay any attention to it. I just kind of plowed through my day. Anyway, I was saying goodnight to my boss, and he was the first one who said, you don't look right. And then I'll give a shout out to my boss at the time, David Ferraro. He said, you just don't look right. And then another colleague sort of did a preliminary test just to test my pulse, and noticed that my pulse rate was elevated too. So they all knew something was wrong, and then urged me to go to the emergency room. I went to the emergency room. I guess I was having the stroke then because I just could not feel. I felt numbness, tinglingness, and then all of a sudden I was having trouble actually opening and closing my mouth, and I was having trouble communicating. That I stabilized enough. So after I was seen, and I guess they had given me some heparin or something to kind of stabilize me, I was discharged, and I was at home. I thought it was kind of like a Charlie horse. You could just kind of walk it off. So every couple of hours, I would just sort of get up around the house and start walking off, thinking I could walk it off. But I was actually having more of the symptoms there. I was actually losing muscle strength on my left side. I could not put any pressure on my left side. I was having trouble balancing myself. I even fell a couple of times. But I thought it was just something I could just sort of walk off. And I had the second stroke. And then on my way we decided that it would be best for me to go to the doctor again to let him know that I was having other issues. And then by the time I got back to the emergency room, I had the third and final ischemic attack. And at that point, I have, it's sort of where I am today, I have left-sided weakness, basically what they call left-sided hemiparesis. And I was having trouble opening and closing my hand. I couldn't do little things with my left side. As a matter of fact, I could not actually lift my left arm at all.
At all?
Yes.
Wow. Dr. Beverly Roberts-Atwater, so what happened in Michael's brain when he had the stroke? What is that?
What likely happened in Michael's case is that he had a blood clot that was lodged in initially one of the smaller vessels. And when they're lodged in the smaller vessels, you have what is called the mini strokes. But those symptoms were clear in 24 hours. But then it went on. He probably showered a few more clots, now in medium-sized vessels. And over on the right side, which affects the left side.
So because stroke is actually blood clots to the brain or blockage of blood to the brain?
That's
is that
one
what it
type.
is?
There are many types.
Okay.
In this case, it's a blood clot, or what Michael called ischemic changes. And there are others whereby your blood pressure goes really high and you have a blood vessel that ruptures. And that's a different type of stroke. Those are hemorrhagic strokes. So in his case, it was more ischemic, and the hemorrhagics are a little different because you end up complaining of a headache that you can't, that won't go away even with Tylenol medications.
So, Dr. Newby, why is it then that so many people, like Michael said, I thought I could walk it off. I thought it was okay. What are we missing in terms of when that happens? Do people think that it's so dramatic that they would pay attention, or?
Well, that's somewhat of a tough question to answer, only because it's always hard to know what's in somebody's mind. But when you talk about somebody that's 30-something years old, the characteristic response is always, there's no way this could be anything serious. I mean, I think even when I was, younger, you feel invincible. You feel like nothing can really happen because you say, I'm too young to do this. That's why I emphasize heart attacks. And I got people 20-odd years old who had heart attacks, but you wouldn't think that would happen to them. And then most people, I think characteristically, people don't like to feel sick. And if they have to take a pill, it's like something's wrong with them. So they don't want to take it, and I can't speak to, Brother Walker in terms of what he was thinking at the time. But, I found characteristically people will say, if I have to take this medicine every day, therefore something is wrong with me. And I don't want to feel like something's wrong with me. So if I imagine it's not there, it's not there.
And it'll just
go away.
So, Michael, were you admitted you didn't take your pills and so forth.
No.
So once you had the strokes, what were some of the things that you had to do to get back to a normal life? And, I say normal life.
Right.
What was your life like once you had the strokes?
Well, I had to make some choices. I had to figure out, there were some emotional choices that I had to make. There were some psychological choices that I had to make, but it was all for my own benefit so I could become better. I had to manage my stress. I had to get a hold of that. I had to figure out why was I mismanaging my stress. And once I was able to conquer that, and that's something that happens daily, over time, I think it went a long way towards my recovery. But as I was going to mention that one of the things that I didn't do when I was in my recovery process was I didn't include the medication part in my, like you get up in the morning and part of your activities of daily life is to wash or to eat. Taking medication has to become part of that routine. It was not part of my routine. And if you're going to overcome something like a medical crisis, you're going to have to make choices, and you have to make better choices.
So when your left side was weakened, did you go through rehabilitation? Yes,
I was in intensive care, and I had some occupational therapy while I was in intensive care, basically going back to the basics of just really getting me to feed myself and develop the muscle memory for the left side so I could actually do simple things, perform simple tasks. And then I got some physical therapy after my hospital stay, outpatient-wise, to help me with balance and helping me with walking and doing some things that would make me a little bit more useful in my own activities, trying to get me back on the road to recovery that way.
You told us a story about the first time you went to the mall.
Oh, yes. That was trying to get back into the daily routine of things, thinking that, okay, I have to function because I have young children. At the time, I had young children, and I have to be a functioning parent. So I remember being at the mall because I think we had to go shopping for something or another, and I had not been out at all since my hospital stay, and it was a scary experience. It was very harrowing. I just seeing people coming at me. I just trying to figure out which way do I go because they're coming at me and just not. You don't want to walk into people, and we're not walking in patterns. But basically, I had to kind of figure out where my spacing was in terms of in relationship to other people actually coming at me. So that was kind of scary, and my balance was not altogether good. So I was prone to fall a lot, which I did a lot as I was recovering from my stroke. I would either trip or fall a lot.
So it's very interesting because that rehab process kind of allowed you to improve your gait.
Yes.
But one of the most important things is that the right side of the brain is that side that's responsible for what we call visual spatial relation, which in your experience in the mall, the reason why you were having it was because of that side of the brain. And the falling as well. So there's
after you have the stroke, then it's hard for you to figure out the spacing or like distance from the floor up, that kind of thing?
That's your visual spatial relation. So that's why Michael was having much more difficulty in an open area with having to perceive what the depth of the situation was. And so even sitting, you have a depth perception when you're sitting, and so sometimes people will fall off the chair, and that's that part of the brain. That was his right side.
So it does, depending on which side of the brain is affected, will determine what will happen to you physically. Is that a true statement?
It helps us localize the areas that we will then know where the impairments are. What's going to happen in terms of an inability to speak, an inability to move the arm versus the leg, which one is weaker. And so it kind of helps us localize. So
in the research that I was doing, and I'm coming to you in just a second, Dr. Newby, but in the research that I was doing, they were saying that when you have a stroke, that when the brain is losing oxygen, that the cells are dying quickly. So that's why you need to get to the hospital fast. Okay. But what is it about rehab that helps you get it back? In other words, if those cells are dying, how do you, are you bringing them back to life, or are you teaching yourself something different?
It's all about re-educating, and the brain is amazing. And sometimes I liken it to if you have a construction zone and you have to detour, and you think about the brain and the way the circulation is. So you've got a construction site, or you got an area where you have to detour. The blood has to find a way to recollateralize and work around that dead area in order to help one pick up on having to utilize other areas to assist them with the function. So we find in the rehab process, the ischemic strokes are takes a little bit longer than your hemorrhagic strokes, whereby you don't necessarily have the dead cell. You have something that's compressing that area. And it depends on how large that bleed is and where it is. But the body is amazing. The blood will reabsorb back into the system. And so the hemorrhagic strokes do much better in terms of rehab.
We have a question for you from Facebook, and that want to know how you know the difference between the kind of headache from a stroke versus a migraine.
That's a very good question. Migraine headaches usually carry with them what we call auras. So you have a headache, you may have some nauseousness with it, you may see spots. Typically, these headaches are in a certain location, frontal or on the side. They're pretty consistent in terms of the pain itself and the intensity. They usually are short-lived. If you take something, it will go away. The headache that's result of a hemorrhagic stroke, whatever you take, it may not go away.
Doesn't matter.
Doesn't matter.
It's also kind of deemed, people may say it's like the worst headache they've ever
Worst
had.
headache
Like,
in the
I mean,
world.
it's kind of like it's going to, a lot of people that have migraines, that it follows a pattern. It's a
Right.
pattern that maybe every so often they have them, but with that one, it's going to be different. It's going to be really severe, and it's going to be like
worst
bam,
ever.
it hits,
And-
and it's bad. It's not gradual anything. It hits and hits hard.
Go ahead, Michael.
And to Dr. Newby's point, Barbara, 4 days before my stroke, I was at a cookout with my children and my family, and I felt this headache. It was piercing. It was like the worst headache I had ever had in my entire life.
Wow.
I remember I was telling my wife at the time, I need to go home because I'm not feeling well. So I remember going home, and I'd never really had a headache that severe before. But I remember it was the worst headache I'd ever had. And then 4 days later, that was when
Yeah,
the
that's when
onset of
things
these.
started.
It's a warning sign.
Yes. So it was a warning sign.
440-2665 or 1-800-940-2240 are the numbers to call to join us. We're talking about stroke today, and we're going to talk about some symptoms. We're going to talk about what's happening, particularly in the African-American community, that makes this disease so prevalent. Dr. Newby, so why do more African Americans have stroke?
Lifestyle and its disease processes. You think about some of the major causes of stroke, they're all pretty consistent. High blood pressure, diabetics, people with high cholesterol, smokers, people that may have heart rhythm disturbances like atrial fibrillation. The problem that we run into is, especially with high blood pressure and diabetes especially, and cholesterol, high cholesterol, is those are characteristically asymptomatic disease processes, unless you talk about extremes.
Okay,
Like
so
blood pressure,
asymptomatic.
yeah, so
Explain.
you got the blood pressure that's like really, really high. Diabetes, where the sugars are like 500 or greater. When you talk about those kind of extreme cases, normally you're going to have symptoms associated a lot of times. But I mean, I have people walk around with blood pressures of 240 over 120, and they say they feel totally fine.
Wow.
And you'll see that, and most people have this kind of thought process that if I don't feel anything, it doesn't matter. I'm therefore fine. And that's the danger. And unfortunately, so, you talk about disparities of health care in African Americans versus non-African American population. Who gets the best care, who doesn't? There's some of that. Then there's mistrust of the system. And when you talk about being African American in a society that hasn't always treated us the same, then you got to deal with, if you go someplace and you're looking for treatment, do you feel you can trust what you're getting? There's a lot to it all, but the bottom line comes, you talk about education. Do they have all the tools, to wish to get the best care? Do they have the understanding of the disease process and what it all means? I mean, I mentioned off the air fights I have with patients regarding medications and trying to get them to believe or buy into the fact they need this stuff. They'll say, well, doc, I feel fine, though. I don't understand why I got to take this every day. And it makes sense if you think about it in terms of saying, like, you have an infection. You feel lousy. You got an abscess somewhere. You say, I feel like crap. If somebody gives you an antibiotic, I guarantee you're going to take it because you want to feel better.
Right.
The problem is you have a disease process where you don't feel bad. And somebody says, you got to take this every day. Think about how you're going to respond to that. Will I make that part of my routine? Because you get up in the morning, you brush your teeth because you want to go in front of anybody. If you're not, you shower because you don't want to go around anybody. If you're not, you eat because you're hungry. You're looking to make a change and make a difference. But see, medicine, when you don't feel bad, it's not making any change that you can physically feel or visibly see. Therefore, it's a lot tougher to get somebody to do that.
If you're just joining us, we're talking about African Americans and stroke with my co-host, cardiologist Dr. Keith Newby, physiatrist Dr. Beverly Roberts-Atwater, and stroke survivor Michael Walker. Michael, I want to ask you a question because I understand from some of your colleagues that on the day or it may have been a few days before, that you came to work dressed very differently than you normally did. That they talked about how dapper you normally came to work, and
Yes.
and that particular day you came in and you had on like shorts and a polo shirt, which for you was unusual.
Yes.
And I wonder, do you remember that?
No,
do you remember
not-
that as
not
part of
quite-
changes?
Not quite specifically
Okay.
that, but I do know that in terms of me changing my lifestyle, I knew that I had to make some adjustments.
Because they were saying this was just before your
before the stroke. Oh.
Yeah. That, in other words, I'm wondering if this also was part of some of the symptoms of what was happening to you without you realizing that it was actually a stroke.
Well, the thing about it is, Barbara, you think you kind of get lost in your own head sometimes about things, and sometimes people see things that you don't see. So it's quite possible that there were some very caring and observant colleagues who noticed that I was not quite myself. And I probably was so focused on what I was doing at that particular time that I had no reason to believe that nothing else was going on.
Yeah, you run
outside of
into
the usual.
you run into people emotional changes, personality changes post stroke, and I'm sure Dr. Atwater sees that a lot. You know, in her rehab world where they get people post, because I mean, I deal with them before, and I deal with them during. And immediately after, she deals with them, well after,
Absolutely.
and I may get them later on back again once they come back in the office setting.
I
So
always
that-
say I'm
Yeah, I
not,
was gonna
I'm
say,
not the
someone-
doctor to see first. And I say, really, I'm the last one. And so when people don't follow Dr. Newby's advice,
They're gonna come
and
see you.
They're going to come see me.
So what are some of the other symptoms? I mean, I think people may be looking for, as I said before, really dramatic changes, where sometimes it may not be.
And I think Michael mentioned some of them, but a few others, other than the numbness and tingling, weakness,
Yes.
blurred vision in one eye. You can have a clumsiness about the arm and the leg, decreased coordination of the arm and the leg. And those things can be very transient, but those are warning signs. And if you have those things and they continue, then please do get into the emergency room.
So if
right
I
away.
was going to say, so if you see a warning sign, then is that the best advice? Just go straight to the emergency room?
Absolutely.
That's what you should do.
Absolutely. There's a time period whereby there are certain interventions can occur that will prevent a large part of the damage. So timing is of essence here.
As a matter of fact, they have an acronym FAST, meaning face, arms, speech, and time, which means if you see something
Absolutely.
unusual in those areas.
And let me
to
just
do
say
that.
also, Barbara, that it's the obvious that we see, but there are other things that are affected, like, Michael's swallowing. So if you're weak on the one side of the body and your arm and leg are weak, everything on that side is weak as well. So swallowing muscles are weak on that side. So you tend to choke and you can't eat certain things. And so people may have bladder and bowel issues that come up. And so, we shouldn't take for granted the severity and extent of what the stroke can do.
So talk to us about the rehab process. Once they've seen Dr. Newby, he's gotten out of the hospital, he comes to see you. How do you diagnose what they need, and what's kind of some of the process?
Actually, the physiatrist role starts very early. So soon as the patient comes into the hospital and they've identified as a stroke, there's a team of physicians that are called. One, neurologist, maybe a cardiologist like Dr. Newby, and then the physiatrist. And our role after the patient is stabilized, after there's no rhythm, after blood pressure is controlled, our role is to identify what are the impairments, what are the things that the patient will be going to have difficulty with. Is it going to be speech? And you notice that Michael's speech is good. There's some strokes that will take out the speech, and that's on the left side of the brain. So my job is to then put together a team of people, occupational therapists, physical therapists, speech therapists, the rehab nurse. And what we do is develop a plan of what we need to do to get that patient to function. And when I say function, I think the very simple things. get in and out of bed, brush your teeth, wash your face, stand. We take those things for granted. That's where my role comes. But to let people know that there is a chance that you can have a quality of life and you can drive after stroke. And that's where I come in.
Michael, I see you shaking your head.
All of those
Talk
things
to us
apply
about
to
some
me.
of those.
All of those things
experiences.
apply to me, definitely, from especially in the rehab process. I didn't realize I still to this day I have trouble with zippers and buttons. If I have to button the buttons on my right sleeve. I have trouble sometimes with that, so I have to pre-button some things. But I've gotten used to doing things that way.
So you've learned some coping skills.
Yeah, it just becomes a part of who you are, and you just accept it. I think it took time, of course. I wasn't really ready to do that. And the other thing was not being able to participate in some of my favorite pastimes. I was a weekend warrior. I love playing basketball, and I love outdoor activities and being involved. I used to run, and I was fairly active that way, and being a hands-on father, that kind of thing. So there were certain things that I had to well, you're not going to be able to do some of these things anymore. And that just had to become part of, you give up some things, but you gain other things too.
Dr. Newby, since Michael has had 3 strokes, he's been through rehab, is it likely that he may have other strokes? And let me broaden that to if you've had a stroke, are you susceptible to more?
Your risk is always probably 4 or 5 times the normal population to have another event, any vascular event, be it heart attack, embolic event, strokes, whatever, your risk is going to be high. Now, what deems the height of the risk is going to be lifestyle. He said, okay, I used to be like this. I used to not want to take this. I used to not want to do such and such. I used to not want to take care of myself. What really reduces that risk significantly is him changing that whole dynamic. One of the things we mentioned, when you talk about blood pressures, a lot of people will blow off that number, and somebody will, the thing that my biggest pet peeve when somebody would come to the office, if I'm just seeing them for the first time or whatever, and they have a pressure of 150 over 90. And I say, you realize your pressure is elevated. Oh, but that's good for me. I'm like, no, it's not good for anybody. Where do you get that from? Yeah. And people will have this idea that, because they've dealt with something for a long time, therefore, that's where it used to be 160 over 100. And I'm saying, but if you have a blood pressure of 140 over 90, anything there or greater, the risk of stroke goes up significantly with each elevation of the blood pressure. And
what are the ideal numbers again for blood pressure?
Well, what you like to see, of course, the best of all worlds is 120 over 80 or less. I mean, that's your best of both worlds. The definition of prehypertension or quote-unquote borderline hypertension is if your top numbers between 120 and 139, your bottom numbers between 80 and 89, that's considered prehypertension. Anything above that's considered hypertension. Now, they say the stroke risk and prehypertension, because most people say if their pressure is 120 over 82, they say that's good. And in our thought process, it was. But your stroke risk is 2 times the normal population at that. If you're 140 over 90, it's 4 times the normal population. And I run into this all the time with people with this. I say every stroke alert I hear at Norfolk General that I'm involved in, their blood pressures are characteristic about 140 to 150 over 90 or somewhere in the high 80s. Characteristically, all of them. Now, you're talking about the intracranial hemorrhage, you're talking about a hemorrhage in the brain, of course, those sometimes you'll see when they're really, really high. They get an aneurysm or whatever, they may burst. You talk about really high blood pressures then. But interestingly, you'll find people that have been chronically really high, you don't see that as much because the body has adjusted, unfortunately, to those high numbers. The arteries get thicker, so they don't burst as much unless you have an aneurysm already formed. But that 140 over 90 range, I'm going to tell you, that is like the danger zone. And trying to convince people that is an issue is the challenge that we all have as physicians or providers.
So another Facebook question. So then the lower number is will determine whether your risk is higher?
No,
or does it matter?
Both.
It has to
It's
be both.
Both numbers. I mean, either or both. In other words, each number is just as important as the other.
Okay.
A lot of people we went through. I mean, I don't want to tell my age, but when I was coming through, of course, it was that the bottom number meant everything, and the top number didn't mean as much. And then as I transitioned into residency and fellowship, then all of a sudden the top number meant everything and the bottom number didn't mean anything. And then I think we have a clear determination that they say either or, because the definition of hypertension is if your top number is 140 or greater, or your bottom number is 90 or greater. That's the definition of hypertension. So if you're 110 over 92, you have hypertension.
Right.
So those are the things they're trying to get people to understand.
Beverly, what are the newest trends, if you will, in terms of rehab? What has changed?
Interesting, and I'm glad you asked that, because some of the things that are out there includes things like the electronics that we're using now to re-educate muscle to get them to function. So there are little devices that we use to put on the muscle to help stimulate the muscle to improve the recruitment of the fibers in an effort to get that muscle re-educated quicker. Those things are out there now. But I think that with technology, we're getting much better in terms of trying to make sure we hone in on the fine motor skill that Michael talked about, that he can't do button his shirts or zippers. And so we try to look at the fine motor aspect and try to do the same thing with the devices to help re-educate the muscles for improvement.
So if someone gets to the hospital in time and you're able to stop the stroke or minimize it, then is rehabilitation almost guaranteed, as they say? In other words, will you get back your function, or does it really depend on the individual?
It depends on the individual. It depends on the stroke. It depends on the type. It depends on, like Dr. Newby said, the comorbidities. If you have heart disease on top of that, if you have diabetes on top of that. So every case is going to be different. It makes it harder. There is a guarantee once you have that triad of diabetes, high blood pressure, and cardiac disease, that more than likely the chances of your stroke being a little bit more complex and complicated, and the rehab process is definitely guaranteed.
And then there's the emotional aspect too of that, all that, and that's
Sure.
wanting not to cut across you, Barbara.
No, that's fine.
What I found in that rehab process too is the emotional part, because it really takes, when they say it takes a village to raise a child,
Absolutely.
it really takes a village to rehabilitate from a stroke or any other life-changing event. And we run into a lot of that where either the patient gets despondent and just really has no real will, or the family is not quite as involved as you hope they would be in terms of assisting in that recovery process.
Right.
Because it almost like you have to have that encouragement from the family to kind of push the individual, and the patient himself, or him or herself, has to have the will to want to get better.
That's
you know,
right.
and unfortunately, so that sometimes people are like that. I mean, Michael's a little different because he's had that will, and he has an intense desire to get
And
better.
you're absolutely right, Dr.
Michael,
Newby.
talk to us though about that. I mean, in terms of your friends, your family, how did all of this affect?
I kind of liken the whole system like a scaffolding. Basically, in my case, there was physical aspects of it, but there were emotional aspects of it, and there were also spiritual aspects of it in terms of my recovery. In the emotional aspects of it, I had to overcome sadness. I had to ward against the sadness becoming depression. So I was in psychotherapy for a while. In the spiritual aspects of it, I sought counseling with a spiritual advisor. I was very active in church activities, and I developed relationships. You're developing a network, and basically you're developing a network of support, and you have to do that in many different ways. And you get more satisfaction out of your life. We all have sadness. We all have it. We experience it every day. But what I was predisposed to more melancholic moments than some, I guess, and that's what kind of led to mishandling stress management situations. But again, without the psychotherapy and without developing a better prayer life, I was not going to get any better than I was.
So, from a cultural perspective, then, what are some of the other barriers that you all see in terms of, particularly our community, in terms of dealing with stroke? I know that we tend not to go to the doctor as often. We tend to ignore things. But what are some of the other cultural aspects that cause this? I'll start with you, Beverly.
I think part of it is just the education and access. I think Dr. Newby mentioned that earlier, and not knowing who do we need to go to. A lot of people don't know what a physiatrist does. I'm a physiatrist. It's a doctor of physical medicine and rehabilitation, and that's all I do is focus on improving function in the face of injury and disease process. No matter if it's a stroke, it could be an amputation. That also there is hope that a person who have had a stroke, like Michael, can enjoy some quality of life and drive again and things like that. But I think the biggest thing is access for us, and knowing that there are physicians who are specializing in the rehab process after that.
Yeah, I think some of the barriers I've found in terms of the actual prior to the stroke becomes partly education and partly just recognition of a problem. Sometimes we would tend to put things off a little bit longer in terms of that, and that recognition aspect, which is key, because if you can reverse the stroke, if you can get in there, and a lot of what we try to do is just dissolve clot, and that's where that time frame comes in, because you're killing off muscle cells.
I wondered what that was. Okay.
Yeah, essentially what happens in a stroke is, if it's an embolic event, you have a clot that goes out and it occludes that vessel. Well, what that area was being supplied by is dying off, because it can't get oxygenated blood in order to function. So when you kind of get in and dissolve that clot, where you reestablish that blood flow, when you talk about waiting for, when Dr. Atwater mentioned earlier about recanalization, or you're trying to get blood flow around by a different area, which is called collateralization, or you kind of new pathways, that takes time for those to open. So, you really only have like 90 minutes or more to get to the hospital.
That really is the time frame.
That's because of those cells dying off. Once they die off, and that's the thing. I mean, when you look at somebody like Michael, who dealt with what he dealt with at 35, 36 years old, this has changed his life forever. I mean, he is because of his internal strength and his faith in God, that's got him to where he is. But most people don't get there because they don't have those support systems available. So you talk about a life-changing thing that you can't reverse. I mean, you can't get that back once it's lost. You can recover it. And I have seen, through the grace of God, complete recoveries. I've seen some people you could never tell they ever had a stroke, but that don't happen that often.
Absolutely.
To be honest with you, people are going to have residual, and that's what I think our barriers become, is that recognition that A, there is a problem that can lead to this, and B, what am I going to do about it to reverse it, to change it? And that's where I found the rubber meets the road with us.
I had an experience with my daughter where she came home from school one day and her mouth was completely twisted. And I immediately took her to the emergency room. I mean, ran in there screaming, she's having a stroke. And the nurse looked and she says, "It's probably Bell's palsy. Calm down." What did she see? Because I was told, if the mouth goes sideways, we got an issue.
How old was she at the time?
She was 17, 18.
Yeah, so you talk about an age phenomenon. That's probably the first thing is going to be, and a lot of people think medicine is really complex, but it's really not in the grand scheme of things. There's a lot of common sense and a lot of understanding what's risk, and then you think about, one of the things we talk about, heart risk. You ask yourself, okay, if somebody comes in with chest pain, I'm looking at age, I'm looking at risk factors. I mean, if somebody is 17 years old that comes to the emergency room with chest pain, who has no high blood pressure, no diabetes, they don't smoke, they don't, no family history, no nothing, I'm going to look at that chest pain differently versus if I have a 55-year-old who has every risk factor known to mankind, not because it's a discriminating issue, but it's a realistic issue. What's the likelihood that this person has something over that person? So when they look at your 17-year-old daughter with no other real probably medical issues, they're saying the likelihood that being a stroke is probably, 0.1%. So then they say, what are the other possibilities? And they hit those first. So that's really what it boils down to.
Okay, because it scared me to death. I will tell you that.
I always tell people, just to make a comment, I tell people all the time when they say, like somebody will come to the hospital with chest pain and then we find that it's not heart. And they always tell me when we see them in the office, they'll say, I was so embarrassed. I know I shouldn't have come. And I said, no.
Right.
I don't want you trying to make that determination. Let us make that determination because our job is to figure it out. I don't want you, because that time you don't come in, it will be the time there may be something going on, and then we missed a window of opportunity. I'd rather somebody feel like they're wasting my time, and I'm going to say this to the audience, you're not wasting my time. If we can determine there's an issue, because we may discover something else. We may find, say you come in and you didn't have that, but we find your pressure's 180 over 100. Well, we've discovered something that we can help you with for the future.
Michael, we got less than a minute. I want you to just say something of encouragement. Exactly. But I want you to say some words of encouragement to others who may be either going through what you went through or maybe even be in the stage you are now. We've learned to live with it, but
I can't emphasize enough just listen to your body. If there's something wrong, don't be ashamed. Don't be afraid to seek help. And I think that was the one thing that I learned about. It's just relying on others. You don't have to carry it all by yourself.
And that's Michael Walker, who is one of our master control operators here at WHRO. So very proud of you. Thank you so much for being on the show. And now I recognize I've been mispronouncing your title, and it is Physiatrist Dr. Beverly Roberts-Atwater. Thank you so much for joining us.
Thank you. And a shout out to the American Heart Association and how important it is to see Dr. Newby. Don't wait because you don't want to see me.
Fantastic. Thank you so much. And Keith, as always, thank you very, very much. Dr. Keith Newby, cardiologist, and we will be right back.
Hi, this is Essie Patha-Murkerson from Law and Order. You are listening to Another View at 89.5 WHRV.
See, the crew did that for me because they know that's my absolute favorite show on the planet. But anyway, vibrant, powerful images that inspire, motivate, and educate currently cover the walls at the Peninsula Fine Arts Center. They're part of a show titled Looking Both Ways, which features the work of several contemporary African-American artists. 1/3 of the exhibit showcases the work of artist, teacher, and author Clayton Singleton. Singleton and the museum's curator, Diana Blanchard-Gross, recently sat down with our Lisa Godley to discuss the new show, as well as to explore some of the backstories that make Looking Both Ways a must-see.
Clayton Singleton's art immediately draws you in, with his use of brilliant reds, vibrant yellows, and majestic blues. But it's the images that take center stage as you look into the eyes of the people he paints. A mother adorned in a purple velvet dress holds her little girl in a protective grasp, while the child's slender arms lock tightly around her mother's neck. Their deep brown eyes, serene yet somewhat sad, staring at the artist who tells their story through detailed strokes and thought-provoking symbolism.
This piece is called The Best I Have to Give. And all these pieces basically relate to the experiences and the narratives that I've had over doing like 20 years of teaching. Parents send you the child they have, whether that child is this phenomenal academic, exceptional student, or somebody just making it, or somebody not interested. To hand your child over to somebody and say, hey, I need you to teach them some things they may need later on in life.
Both the mother and child's heads are encircled by a bright yellow spiral. Singleton says it's an African tribal symbol meaning all in, giving them a Madonna-like halo.
That is the power, that is the esteem, that is the emotion with which I want to connect the people. That's a big deal. I mean, they send you who they have. And it's a heartfelt gift, if you will.
Singleton, who grew up in Norfolk's Park Place community, has named his series Valedictorian. He says it's designed to celebrate the legitimacy and prevalence of intellectually exceptional African-American students. Museum curator Diana Blanchard-Gross explains why she wanted Singleton to be a part of this show.
I wanted to have that local element and called on my good friend Clayton. And I told him, I said, this is what I'm doing. I'm looking at African-American artists who really use their cultural heritage as inspiration for their work. He created all these works just for us. These have never been shown before. I'm so honored.
Among his works, several paintings of the Norfolk 17, the first African-American students to integrate Norfolk Public Schools.
I was thinking about stories I'd heard growing up, and my mom used to tell the story about how Norfolk shut down and how they didn't go to school. And my uncle was really the only sibling that went to Maury High School, and everybody else had to go to Booker T. Washington High School. And so, I've heard these stories over and over, and it represents ways through which the social landscape changed through actions of groups of people or individuals.
In addition to capturing the faces of the 17 students, Singleton's version incorporates a bright yellow ruler, which stretches from one side to the other.
In the pieces, the rulers represent standards by which others are measured. That was a perfect icon to use for society's measuring system for African Americans. And the handles that are on the side are actually drawer handles, and they represent access, because we use door handles and drawer handles to gain access to things, whether they be opportunities or whether they be physical destinations or whether you need something out of your junk drawer, right?
While Singleton celebrates the scholars and the trailblazers, he also looks at the students who don't get a lot of attention. One of his favorites is titled, "What Is It About Me You Can't Teach?" He began to tear up as he described the young man in the red baseball cap, white t-shirt, and sagging blue jeans who was being ignored by his teacher.
What is it about me that allows you to walk past me while my head is down and not say anything to me at all? Am I better off not interacting? Are you better off not engaging me because that's more comfortable? And in this picture, his eyes aren't seen. And that's significant because a lot of people don't see black males. You can see me on the football field. You can see me on the track, but you can't see me in the class. That's hurtful. That's why his eyes aren't there. And these symbols represent that, I can learn, basically. The education is important to me.
If you'd like to see Singleton's work, you can log on to WHRO.org/The Scene. For Another View, I'm Lisa Godley.
Wow, some powerful, powerful images. Go check it out. Looking Both Ways runs through March 22nd at the Peninsula Fine Arts Center, and you can see the exhibit for free on February 7th and 8th. And on February 19th from 6 p.m. until 8 p.m., the Peninsula Fine Arts Center will showcase 2 WHRO The Scene videos, which feature African-American artists Asa Jackson and Godchild The Omen. Before we leave you today, I'd like to say a very heartfelt thank you to Edith White, the board of directors and staff of the Urban League of Hampton Roads. It was quite an honor to receive a Martin Luther King Jr. Community Service Award this past Monday at the MLK breakfast. I was proud to be recognized along with community leaders Robert Ayers, Gilbert Bland, Eric Fox, Bruce Hacker, and Deborah Stearns. And a very special thank you to my colleagues and friends who got up bright and early on Monday morning, despite it being a holiday, to celebrate with me. Lots of critical information on stroke today, so if you want to hear our show again or share it with a friend, please visit our website, anotherviewradio.org, and download the podcast. Next week, preparing your kids for a career after college, we talk with William Holland, author of The Path to Backpack to Briefcase. Parents, this guide is for you. Our theme music was composed and performed by Jay Sennett. Lisa Godley is our show producer. Victor Bowen is our audio engineer, and Chantel Davis was on our phones. I'm Barbara Ham Lee. Have a wonderful weekend, everyone. And let's get together again next Friday at noon for Another View.